right, so we'll go ahead and get started. First, thank you for coming to our 2024 Consortium meeting. Drew Hazelton, for anybody that doesn't know, Chief of Operations at Rescue Inc. I do want to just go around the room and everybody introduce yourself, where you're from. This is more of a formal setup for an informal conversation. So just so happens the classroom kind of set up this way. But please ask questions. You can just shout them out. You don't need to raise your hand or anything like that. So if there's something that you want to know, more information, I'll gladly share everything we have. So if we could, we just want to start going around the room and.
Yep. I'm Fran Shippey, a selectman from Chesterfield.
Judy Idlecope, also a selectman from Chesterfield.
Oh, I'm Jeanette White, I'm the Putney rep on the board.
Deb Chapman at large on Rescue's board.
Kate Jansek, I'm a selectman for Townsend.
Josh Brooks, facilities manager.
Eric Wilson, assistant chief.
Billy Strauss, EMS in Putney and also affiliated Rescue.
Chris Manell, I'm the director of special programs at Rescue.
Danielle West, I'm the administrator here at VEMSA.
Karen Walsh, admin assistant at Rescue Inc.
Alan Walsh, director of administration for Rescue.
I'm Todd Davidson. I'm on the Dummerston Select Board.
My name is Zon Eastis. I'm on the Guilford Select Board.
Karen Astley, Town of Putney Town Manager.
Stan Noga, kind of a rep for the town of Brookline and a select board member.
Wynn Clark, Newfane rep on the board.
Harold Newell, Dummerston's rep.
Kathy Hagee, Townsend's rep.
All right, so I'm going to go through some slides. Hopefully this is not too painful, but again, if you need any clarifying information, please ask. So a couple things for everybody that doesn't know. Rescue was founded in 1966. We've been serving these communities for almost 60 years at this point. We're super excited about what we do, and certainly the pride from 1966 continues today. So our mission, I think, is really important. As a nonprofit, we are mission driven, and every day we strive to make sure that we meet these three objectives that we've set for ourselves. And we do that through a whole host of different programs, including kind of our traditional programs of EMS, as well as many expanded programs that we currently offer. So we cover about 500 square miles, 14 towns, including 2 in New Hampshire, the rest in Vermont. That's our primary 911 coverage area, but that's not the only area that we work in. We do provide a lot of services outside of that primary 911 coverage. So I realized, I was actually talking to Ellen, that we actually haven't had a meeting since January, so it's been about 18 months. So what we're looking at here is our fiscal year statistics, so July to July. We're currently operating 2 stations, 14 towns. Again, you can see the equipment that we have on the road currently. We've downsized our ambulance fleet slightly from the peak that we had during COVID. During that window, we actually increased the number of ambulances because the decontamination cycle was taking so long. So we're now down to 10 ambulances. I think the key on this slide is EMS is more than just owning an ambulance. It's really a complex system of healthcare delivery outside of the hospital. And keep that in mind as we walk through what it is that we're doing here at Rescue. It is a complex system of healthcare. And we are the true social safety net. It doesn't matter what time of day, what day of the week. It doesn't matter if you're insured or uninsured. It doesn't matter if you're a resident or non-resident. We answer the call every single time. Which brings us to our traditional EMS group, the group that we call our operations group. These are the ones that answer those 911 calls. 5,800 calls last fiscal year, I'm sorry. Every one of those calls answered without the use of mutual aid. 100% of those calls covered by our crews, our staff, and our ambulances. That's something in today's world. That is a system of on-call, that is a system of understanding the statistics around the way EMS calls come in, anticipating when those are going to happen, increasing staffing during storms, It's really a system that's been developed over the last 58 years to serve this specific region. But 5,845 calls without mutual aid. Anything else you want to add, Wilson? Amazing group of people that get this work done. And but 5 cardiac arrest saves. 5 people that are with us. And we've had 2 additional cardiac arrest saves in the last 2 weeks. So these are the 5 from last year. All right, so yeah. Terror, right? This is where we work. We work in people's worst days. We work in people's most difficult times, whether that be a massive car accident, a horrible cardiac event, cardiac arrest. And in order for us to be there, it takes us hours and hours and hours of time and preparation. It is the cost of readiness. I think we need to make sure that everybody understands that it's not every day that our crews are out 24 hours a day. Our crews may have hours where they do nothing, and then hours where they run back to back to back, life-saving call after life-saving call after life-saving call. Our teams may train for water rescue for years, and then it's not until that moment when the flood hits that it's important. So our world is expensive. The cost of readiness is expensive. We prepare for hours so that in the moment we can do the job that needs to be done. That's important to those 5 lives that were saved. That's important to every one of our patients that were at the top of our game. So beyond ambulance service. So Rescue Inc. is not just an ambulance service. We're a complex system of out-of-hospital healthcare. So our technical rescue team, completely volunteer. We have a group that's based in the southern part of the state. We also have a group that's based in Killington now, about 35 personnel. And those personnel are charged with bringing the patients from wherever they are. Human beings do some crazy things and they get themselves into some interesting situations, bringing them back so that we can provide them the medical care they need. Whether it's in the swift water, whether it's hanging off a rope, whether it's lost in the woods, that's where we go to find those people. Again, hours of training. An average volunteer on our technical rescue team is putting in 200 hours of training a year on top of the calls and deployments. Other things you don't think about when you think about traditional EMS, fire scene rehab, the need to cool off our first responders while they're dealing with fires or heat them up in the wintertime so they can get their rest periods in. Mass casualty supports. Unfortunately, there's plenty of news coverage about multi-victim incidents and active shooters. We have equipment to respond for mass casualty sheltering, as well as we have response trailers, and we provide plenty of event coverage in order to help make sure people get the care they need when they need it. Public health. So our role in public health didn't end with the end of the pandemic. Last fall, we were out once again providing public access clinics in our region. We'll be out again this year in partnership with Brattleboro Hospital doing more public health work going into the fall. Mobile integrated health. This is an exciting new project. It's been up and operational since last November. We're working with Brattleboro Hospital. We have an orthopedics program where every patient receiving total joint replacement is being seen by our mobile integrated health team. It's helping to prevent their readmissions, improve their outcomes, and certainly their patient satisfaction. Chris, do you want to talk anything about our orthopedics program?
It's a unique program, and we utilized it to be the starting point to be able to learn what we needed to know in order to be able to integrate with the hospital. The future expansion of this is pretty substantial. The hospital wants this as a very significant program to help them going into the future because of the challenges that we have in healthcare. For those of you who don't know, the population's aging pretty rapidly in this region. Currently, over the age of 75 is 12.5% of the population in Windham County. By 2040, that's going to be 22%. So it poses a very significant challenge to the future of healthcare in this region.
So the next piece of our program, starting October 1st, is centered around treatment and care of COPD patients, with a goal to keep those patients out of emergency rooms. So if you think about it as options-based care, so rather than having to wait until patients hit the point where they're in such extreme circumstances that they need to call 911, we're going to be that safety net in the middle, where you're not really bad enough to need an ambulance, you don't want to call an ambulance, but you need some help. That's where we're inserting in our partnership with Brattleboro Hospital, so that we can get people the care they need so they don't end up going to the hospital. Certainly, if they get to the point where they need an ambulance, we can provide ambulance service as well. But our goal is to keep people healthy, keep them out of the hospital, and intervene and treat them before they get to the point where they need emergency room level service. So we have a partnership with the Brattleboro Retreat. We provide statewide specialized mental health transport. So anytime there's a patient that cannot receive transport for their mental health condition to the Brattleboro Retreat, that's not only in Vermont, but also in New Hampshire, any patients accepted by the retreat, we are the default transportation agency for them if the local ambulance service is unable to serve their needs. All right, so VEMSA, you're all standing here, opened in 2022. Nice little heat map showing our first year's worth of reach. That's our student location, so we've been traveling about, getting on the road and teaching people from across the state and a little bit into southern New Hampshire. Some stats, 358 separate programs we ran in the last year, with 2,200 plus individual students coming through our education programs here. We have EMT, advanced EMT, we have first responder classes, as well as CPR and all of the specialty courses we need for EMS providers. They're provided here on site, and they're also provided remote for people that need them delivered to their local communities. So we have education programs specifically running with some of the towns. For example, Putney, we do provide the education to their to continue education as well. So education's complicated. And I put this up because in the last 2 years, the entire framework for which EMS education is taught has changed. So we used to have national registry classes, and then we'd have national registry practical exams, and every student would sit through a class and they'd take a computerized test, multiple choice test, then they'd move on from that and they would go take a practical exam. That was all changed effective July 1st of this year. The National Registry is no longer doing psychomotor testing. All of our education programs are now portfolio based, which means the burden of teaching those skills and evaluating those skills stays here within the educational organization and not through a third-party evaluation. Unless, this is nationwide by the way, unless you're from the state of New Hampshire, in which case New Hampshire has created its own special test that mirrored the old test that everybody else got rid of, and we're still trying to figure out how to make that mesh together. We're hoping that maybe New Hampshire will come on board with the rest of the states at some point. But right now, New Hampshire students still have to go back to New Hampshire and take a test because Vermont doesn't even offer those tests anymore. So here at VEMSA, we don't do just EMS training. We offer technical rescue training, including animal rescue, boat operator classes. The vast majority of the responders that have been out for the last 2 years worth of flooding across the state were trained here. So we have a pretty robust water rescue training program every spring when there's actually water in our river. We don't run those the rest of the year for obvious reasons. So some more things about VEMSA. We have I think the only Pearson testing site other than Burlington in Vermont. So our students, when they need to take their practical exams, their written exams, can come here. We offer the computer-based test along with 6,149 other tests. So if you're needing to do testing, professional testing, whether that's for a teaching license or trying to get into the Secret Service, all of those exams are offered here. Another program that we worked on last year, we're super proud of, is our relationship with the local high school and the Rebel Responders. So as part of their project-based learning, we're teaching the students not only first aid, CPR, but we actually trained some of the graduating seniors all the way through their EMT, and they're ending their high school year with a medical license as part of the program that we're running with them. Exciting program, doing it again this year, really good results and reviews from last year's program. So some awards that I think are kind of noteworthy. Mission Lifeline. So unfortunately they don't have the plot map out yet for the 2024 awards, but you can see if you look in here that Vermont does not have many agencies that qualify for Mission Lifeline awards. We were a gold recipient. This is our 2024. We were a silver recipient in 2023, which means we've improved our stroke and cardiac care even more. So this is the highest level of award we can receive for cardiac and stroke care. So we're one of 3 agencies in the state that were awarded in 2023, and I don't know how many were awarded in 2024, but we'll wait and see when that comes out. So huge shout out to our operations group. They're the ones that made that happen. And I'll say it again, but they're really second to none. So to add to our awards this year, our water rescue team had the pleasure and privilege of going out to South Bend to receive a Higgins and Langley Memorial Swiftwater Award. It's an international award for Swiftwater Rescue. We were the only US-based team to get recognized in 2024 for water rescue. So, like I said again, our technical rescue team is really second to none. So, we didn't leave VEMSA behind. Our group here at VEMSA, they've been working their butts off, and they are the only active organizational accreditation for the state of Vermont. So that means every program at VEMSA now is CAPC accredited, which will allow us to continue to provide education going into 2026 and beyond. Starting in 2026, all continuing education for EMS licensure will have to be CAPC accredited. We are now the only fully organizationally accredited institution in the state of Vermont. And that includes the state college systems that are not accredited yet. So they're second to none too. So we did some fundraising. Shout out to the fundraising crew and everybody that went out and played golf last weekend. Super successful fundraisers. So, and wanted to give our event sponsor a shout out here, Benedict Enterprises from Hinsdale. We greatly appreciate the support and look forward to the fundraising effort for next year. All right, so subscription program still up and running. If you're not familiar with this, you should be familiar with this. This is an important program. Helps especially people that are on fixed incomes not be exposed to the cost of ambulance transport. And anybody that wants more information about that, I can give it to you afterward. But how many households do we have now, Ellen? 20?
Yeah, over 800 households in our coverage area that are subscribers.
Excellent.
And we have brochures up front where you signed in if you want to grab some of those.
So we've been very busy looking to improve. So as part of our goals for the next year, we're improving our mobile education simulation trailer. So we have one out here. It's a 32-foot trailer. It was repurposed after the pandemic. With some support from the EMS Fund and Thomas Thompson Trust, we have ordered a brand new customized high-fidelity human sim trailer that we'll be using to bring those education programs to more remote locations. So if you've walked around our building, you'll notice that we have mannequins here that are not just mannequins. They breathe, they talk, they have vital signs, they bleed. And we want to make sure that access to that equipment and the training that goes with that is not just here in Newfane, but we can take that on the road to the towns that we serve to the communities that surround us and really get their hands on that equipment. And this trailer is going to let us do that. We should have that in here in another month or so. So we received a grant this summer to train some youth. So we had youth from all over the state that came here to VEMSA for a 4-day program in Vermont First Responder and High Angle Rescue. They came down, they stayed here on site, and they left here with entry-level medical certifications by the state of Vermont, and went back and joined local departments around. We had, I think the furthest one came from
It's in the Northeast Kingdom. I can't
somewhere
remember
way up
the
north,
exact
Northeast
town.
Kingdom. So it was a very exciting program, and we look forward to probably running that again next year. So another grant that we received for the West River Valley is very specific to the West River Education District, which is this area up here, is to provide CPR and first aid training to every faculty member along with every junior and senior that will be graduating from high school. So we started that. First students have started coming through, and we're excited to be able to offer that program up here. Questions? All right, that's what we've been doing. It's been boring. So let's talk about EMS stress, because there's some things that stress us. All the questions you're throwing at me are causing me stress. All right, so what do we got for stress? Well, I put the golden dome up on the screen. I can guarantee it causes stress, right? So what are legislators doing to us as opposed to for us, right? So Vermont passed some legislation this year. Now, New Hampshire is in the process of passing some legislation too. But we'll talk about Vermont's legislation. And I'll talk about New Hampshire after that. So Act 152, this is kind of a big piece of legislation. In case you're wondering, EMS is now essential in Vermont. It's a great little title. We can wear a pin. It doesn't really do much for us, but we are now essential. It's supposed to increase Medicaid reimbursements for treatment without transportation. So ambulance services traditionally, if they went to a patient's house, they treated a patient and they left, there's no reimbursement for that. So about 20 to 30%, depending on the area, depending on the town, of all the EMS calls do not result in transport, which means those are not reimbursable. So in Vermont, we passed legislation that said that patients that are on Medicaid that receive that service, Medicaid would reimburse the ambulance service. So keep in mind, that's about 17% of the total population and about 20 to 30% of the calls in that population. So it's not a huge number, but certainly a good start. There's been legislation introduced by Vermont's congressional delegation. It's called the EMS ROCKS bill, which would make it a federal law that Medicare would have to pay for those same services. So I don't expect that to get anywhere in Washington, but we do have, our delegation has introduced that from Windham County. And then we had some language about doing an assessment on the cost of delivering EMS in Vermont. And this is where it kind of follows the same path that's going on in New Hampshire. So in Vermont, the health department has been tasked with assisting the EMS advisory committee in doing a complete assessment of EMS for the state, including training, education, personnel, and the cost of delivering service. New Hampshire took a little bit different approach. New Hampshire put it in the Department of Financial Regulation, and they are currently requiring all ambulance services in New Hampshire to file cost reporting, much like the federal government. So either way, what we're going to have in another year or so is a complete picture of the cost of delivering EMS service in both the state of Vermont and the state of New Hampshire. It lines up with the timing of the federal government, who implemented cost data reporting in 2018, then delayed it during the pandemic, and this is the last year of cost data reporting on the federal level. So we expect a report back from that in early 2026. So right around 2026, we're going to have all of this data that says what it costs to deliver EMS service, specifically in Vermont, New Hampshire, and on a federal level. The other thing that happened in Vermont is there was a little bit of increase in our special fund from $150,000 for the entire state to about $450,000 to help offset the cost of ongoing education. All right. So I'm stealing some slides. I'll give Oliver Wyman credit because this is part of Act 53 in Vermont, which is a report card for the hospital system in the state of Vermont. Anybody that has not read that report, I highly recommend you go to the Green Mountain Care Board's website and read the report that came out from Oliver Wyman on the state of our hospital system. And I bring this up because there's some things here that are kind of interesting. If you look over here at the cost of health insurance in the state of Vermont, that's what we're paying as a company. You'll notice that from 2018 to 2024, we've had a 108% increase in our insurance premiums. That's what we're putting out. The cost of health care in the state of Vermont is climbing at a rate that is far higher than the actual revenues of people. So it's a pretty bleak outlook when you look at the cost of healthcare delivery in Vermont versus what we have going on. So they make some recommendations, and I just want to bring your attention to one right here. So priority for transportation programs for the Agency of Human Services to start in 2025. By the way, that's like 5 months from now. Okay, so they are predicting, if you read the report, that our healthcare system is in such crisis that they must start acting in 2025. Number 2 on their list. The good news is we're already there. We're already professional and regionalized. That's excellent news. We're heading in the right direction. The one I like to see over here, Vermont legislators, pay for it. So if there's any legislators in the room, number 2 priority, it should have been number 1 in my opinion, right? We know that we're regionalized, we know that we're professional. And we also know that the legislature needs to pay for it. Because the hospital system requires viable EMS in order to be effective. Okay? All right. So, does that make sense to everybody? All right, because this is going to get real murky now. This is some federal stuff. If you're really, really, really bored, after you're done with the Oliver Wyman report, go to CMS's website and look up Ground Ambulance Patient Building Advisory Committee. This is a 160-page document, and I have not put every one of the slides up here. But what I have put up here is some things that I think matter. One little clip. And really what this whole report says is that we need to make sure that insurance companies are paying for ambulance transportation. It is not reasonable to expect that ambulance services are going to be, quote, in network. This is part of the balanced billing legislation. Okay? You don't get to choose who your ambulance service provider is. You're driving down the road in Pennsylvania, you get in a car accident, you call 911, an ambulance shows up. You can't check if they're in network or out of network. That's not even a reasonable thing to expect. So what they've done is they've looked at this across the entire country and said, hey, we need to make some changes, significant legislative changes, in order to make this happen. So I bring you back to this slide. This is kind of fun and exciting because insurance companies don't like to pay us either. If you look, Vermont is the lowest when it comes to commercial reimbursement for ambulance services. We would like to be one of the higher ones, but we're not. So there's legislation that is being written on the federal level to change this entire process to make sure that the insurance companies are required to pay ambulance services. At the same time, because states don't believe the federal government is going to get it right or do it fast enough, they're moving on their own. Bring us to our neighbors over in New Hampshire. New Hampshire's ahead of Vermont in this particular world. New Hampshire actually has legislation that is pending that we believe will actually pass that will require ambulance or private insurance carriers to pay ambulance providers directly 325% of the Medicare. They're not the only states. Washington State's already passed it. I can go down through the whole list and click a whole bunch of slides. Louisiana's already here, 325. The rate has been set and determined by the study committee that we talked about on the federal level is that a reasonable reimbursement rate is 325% of the Medicare allowance. Why do I bring this up? Because you're going to see in your packet that we're sending you, as part of our agreement for the next 3 years, we have adjusted our rates to match the 325% for commercial payers, the same as everybody else in the country has done. That's the background behind it. So if you're looking at those numbers, saying where they come from, I can flip back a slide. They came from right here. That's what the law is going to read in New Hampshire, and we're very confident in Vermont as well. We're letting New Hampshire fight this one, then we're going to point to it and hopefully get it passed in Vermont. All right, so moment you've all been waiting for. What does this mean for your tax dollars, right? Last year I led with the slide, and then everyone was like, yeah, I don't want to pay attention. So this year I held off on it so you guys would have to at least listen a little bit. So our board has decided to offer agreements to everybody for 1% a year for the next 3 years. I can't think of anything more fiscally responsible than that. Certainly your budgets in other areas are not going to go up 1%. But I'm going to put a catch up there. Last time we had this conversation, 4 months later, Brattleboro got up and walked out and left us all hanging, and we've been scrambling ever since to try to make sure that our financial stability existed and we were able to continue to provide the services. We can't do this unless we get everybody on board for the next 3 years. We need the mass in order to make this viable. So we are going to put out your agreements early this year. We know you're going into budget cycles, and we're asking to get those back before the first of the year. Because if we don't get them all back, then we'll have to make adjustments to the cost because we can't simply absorb another massive change like we did before. All right. So, good.
So that's the current status, is that Brattleboro is not participating?
Brattleboro does not participate, correct.
How do they cover their EMS services?
They bought ambulances and they have it now provided to them through their fire department. All right, and I'm going to tell. So I almost took this slide. Jet's seen this slideshow because part of it because I used it at an event she was hosting here, and I was going to take it out, and I'm like, you know what? I get to stand behind the podium, so you guys got to listen to whatever I want to put up. So this is actually last summer, and I realized that I haven't talked to you since last summer. But if you remember last summer in July, we had this unnamed storm that came through and just clobbered this area. Not only here, but New Hampshire, north of here, south of here. It was pretty ugly. And I was super impressed with this organization and what happened here. During the period of time, we knew that we were going to get destroyed. We knew that the roads were going to wash out. We knew the bridges were going to be swept away. We knew that we were going to be isolated. And we called in our staff, and we staffed every single ambulance that we owned. Fully staffed to the point where we had more people than we had positions to actually staff. We called in our technical rescue team, and we weren't able to put up just one team. We put up 3 Type 3 Swiftwater teams. What that means for people that are not into the kind of the NIMS world, the National Incident Management world, is we put up 3 completely independent, self-sustaining teams that the state was able to utilize in all areas of Vermont, as well as taking calls into New Hampshire. One of our teams actually took multiple calls in New Hampshire at the time. But to be flood ready means that we spend a lot of time training, a lot of time equipping, a whole bunch of time sitting around playing cards waiting for the next flood to come. But being flood ready means that operations is staging their trucks in different locations. We're borrowing space at local fire departments to make sure that if we do get geographically isolated, that we have ambulances in places where we need ambulances to be. It means being there when the flood happens, being ready to go into areas and places where most people wouldn't go. Swimming through clouds of propane. It means just before darkness, jumping off a roof and swimming down the river to save a guy that's pinned on top of a hot tub 100 yards in front of a sewage treatment plant that's under 8 feet of water. That's what our team does. That's what our organization does. This, by the way, is a rescue that we got the international award for. All right, so this brings me to the end of my slideshow. What do we have for questions? It's gotta be something. Yeah, go ahead.
Very general. So I'm here because the select boards are going into budgeting season. And, you know, in the case of Townsend, each selectman is being asked to focus on specific areas of the budget. And I drew a lucky straw of doing Rescue Inc.
Oh, excellent.
And so that's the context. My general question is, how do you determine what the charge is to each of the communities that you're including in this coverage area? That's a big question, I know it.
It is. The good thing is I have an easy answer. So there's no, are you familiar with the education funding formula?
Please?
Are you familiar with the education funding formula in Vermont?
Are you kidding?
It is nothing like that at all.
Oh, thank
Because if it was, you couldn't understand it at all.
Right.
So it's actually pretty straightforward. So way back when, long before my time, Rescue started having to charge the towns an assessment in order to fill in the gaps that existed in their operating budget. Every year, our board looks at what it costs us to operate, where our rates are, and determines what percentage increase they believe that we need in order to continue moving forward. In an ideal world, that number would be nothing, but costs do continue to go up. So there's no direct correlation between the dollar amount and any particular measure. It's not based on inflation costs or anything else. It's based on what the representatives, that represent every single one of the communities, vote. And this year they voted to increase it 1% a year for the next 3 years. Yep.
But I think, didn't your question include, how do you come to the base?
So,
I mean, what is that based on?
So the base goes back 20 plus. I have no idea where the original number came from. It's been a percentage increase year over year for as long as I've been here.
But I think
$25 a head, isn't that what you?
Right.
That's what it's based on.
Basically, what she's asking is the fact that it's based on population.
I'm sorry, I thought you were asking where we came up with that number. Yeah, so it's based on the census. So, so one thing that does change it is when the census comes through town, right? We adjust that, and it's based on the per person in the town. But where the original number came from, that's lost somewhere in history. I will say that the average in Vermont right now is about $75 per capita. I have no idea what it is in New Hampshire. So we're about 30% of the average right now in Vermont. Yes, you had a question up front?
No, you answered it.
Okay.
Answering that question, sorry.
And you'll notice that Halifax is a little different because we only cover a couple of towns down there, so theirs is not per person based. But there's nobody from Halifax here, I don't think. And Stratton, Stratton is unique because Stratton actually pays for services and then doesn't use them. So, yeah.
So a couple things. I'm very impressed what you're doing and what you have been doing for many years. And congratulations on the awards. I mean, it's very impressive. This place is impressive. So 1% for the next 3 years. When would you, so if a town does not sign a contract?
Yeah. So,
which I hope they all do because we need this service. When would we know?
that's why we're asking for everybody to make their decisions by the 1st of January. That way, if we do have to make that adjustment, there's still time ahead of your
July 1.
your meetings. Because there is, so keep in mind that there's, kind of two parts to the revenue that we receive from a town. So there's the direct revenue, the assessment, but there's also the patient revenue that comes from that. And so, for example, if Dummerston was to decide they didn't want to get service from us anymore, it doesn't mean that we can reduce expenses. Because we still have to keep those ambulances on. That readiness cost exists whether one town comes or one town leaves. It really has no impact on that at all. So that means we have to, at that point, look at the budget and try to figure out how we share that cost across the rest of the system.
Follow-up question. So I'm not quite sure what your staffing is like, but do you look to add other towns if you can?
So the answer is we have in our bylaws the ability to add towns. So Rescue, keep in mind, Rescue is a nonprofit. So we can add, they wouldn't be member towns, they'd be contracted towns. The challenge is that adding additional towns quite often would mean adding additional ambulance crews. And the cost of putting in an ambulance crew on 24 hours a day is about $1 million a year, $1.1 million is actually the most recent estimate. So adding additional towns without that additional revenue would create kind of challenges. So we don't go out looking for it. I know we haven't met for a year and a half. There was a period of time where we did step in and help Cheshire County when Deluzio suddenly became unable to continue, and there was a 3-month window where we helped transition that area, and then we helped Keene Fire transition for 3 more months after that.
Yeah.
And when we offered service to them, we offered it at a rate that would have made it so that it was sustainable over there. And unfortunately, that rate was too high for them. But the cost of delivering services is what we'd be looking at.
Thank you.
Yep.
This slide in particular would be very informative and useful in select board discussions. Is it going to be included, or are we going to be receiving copies of these slides?
You'll receive, so the slides, so we're going out on BCTV. I should thank BCTV for being here. So you'll have the entire presentation will be available online, and then you'll be receiving a letter from the office with the information in it as well, shortly after this meeting.
Drew, I just had a question about overall, like, the diversification into the different kind of lines of business, if I can put it that way. Like, has that in any way helped offset, if you will, the sort of crunch around providing the core EMS service? Sort of what is, I guess, the business strategy in terms of the expansion? Because you're covering so much ground with these different projects and different ways of delivering service to the community, and is there a danger of it being so big that it's hard to manage, or is it actually helping the bottom line, top line and the bottom line?
So the answer is yes, it's big, it's complicated to manage, and yes, it helps. So I guess I'll take it in a couple different areas. So the mobile integrated health is the future of EMS. So, though that is being managed as a program here at Rescue, it's only being managed as a program separate from EMS because we are ahead of the state in the development of that program. By January of 2026, mobile integrated health is what we're calling it, will be the base of modern EMS delivery in Vermont. New Hampshire is going a little bit different path, so we'll have to do a little bit different stuff in New Hampshire. And the reason for that is that slide, if I go back here, is the cost of healthcare in Vermont is skyrocketing. And what it's been, as they kind of look at that issue, what they've determined is that we're not providing care to places where people need the care, closest to home, at the lowest possible cost. We're actually doing quite the opposite, where if you can't get access to your primary care, for example, then your situation gets worse and worse and worse, and then you call 911, and then the insurance company is paying for an ambulance ride and an ER visit and maybe a hospital stay and whole bunches of tests. Well, our mobile integrated health program is designed to stop that downward spiral by getting there early, treating that patient. In our mobile integrated health programs, we can provide telehealth, we can provide on-site testing for them, EKGs, ultrasounds, and other tests that their physicians can directly see in their home, medications, to prevent them from getting worse. So that program, though it is managed separately, is the future of EMS, so that's super important to us. It does also help engage our staff. There's higher expectations, higher education. They get to practice as healthcare providers. As far as like our technical rescue program, that program has proven to be huge for the organization, not only from our kind of staff satisfaction, but being able to bring in additional resources. That team is completely volunteer, so when we have the need to surge personnel, we can draw in those 30 volunteers to help bring up our total staffing. The other cool thing about that program is because we are a state team, so we are one of a handful of teams that the state calls on, we are also reimbursed. So that team actually generates revenue in excess of what they spend as part of their statewide deployments. The retreat program, very similar in the sense that it was a need. We filled the need, and that not only helps to kind of balance that bottom line, but helps to fill that void that existed. So the answer is yes, it's complicated, but absolutely it's helping to provide this really stable footing that we're on right now. Yeah, keep them coming, I like it.
I think you answered this question, and this is a really ignorant question. You mentioned the technical rescue team, and you said that those calls, those events are reimbursed. That was really my question is, are you reimbursed? By whom, or by what entity, what resource reimburses you or compensates for technical rescue events?
So if we're performing technical rescue events in any of our local communities on a day-to-day basis, then there's no cost and no reimbursement. That's just done by the volunteers that are part of our team. Where we do get reimbursed is every time that we're activated by Vermont Emergency Management. And we're one of the state teams. So for example, we've been activated 4 times this summer, Josh. So every time they call and activate us, we've been to Lyndonville, Berlin. I've been to Lyndonville multiple times. And then last summer we were activated for 7 or 8 straight days by emergency management. That was actually picked up by FEMA due to the massive flooding.
Okay, thanks.
We're good.
All right.
Oh, sorry. The orthopedics and COPD programs, do those extend to Chesterfield, or is that only for Vermont residents?
So they will soon be extending to Chesterfield. New Hampshire has a very different process than Vermont. So we worked through the Vermont process. Everybody's familiar with Dr. McClarney. Dr. McClarney is the medical director for that program. Part of the submission package to New Hampshire involved us having to prove some things, so we have a year's worth of data. So on the anniversary of that program, which will be November, we'll be kicking that program over to New Hampshire.
And does that only apply if they go to BMH, or is that?
It does right now. Grace Cottage Hospital will be joining our mobile integrated health program later this year. We're not sure if anybody else is going to jump on board or not. Cheshire is a different animal over there because of the...
And do you search out those patients, or do they have to come to you and ask for those services?
They're referred by the physicians. Yep. The only place we can't go, and we will not be going, is Massachusetts. There's an $80,000 application fee down there.
You have a question, Dan?
Well, he just answered it actually by saying it's triggered by the physician and not a clearinghouse between the hospital and the physician and you.
No.
Okay.
Yeah, what they're looking at are patients that have risks. So they're looking to identify those patients that are going to need additional help. So if you're a COPD patient and you have been admitted a lot and you're struggling to manage your COPD, those are the type of patients where, for us, I believe post-admission is going to be 5, Chris? How many
Let
visits?
me go on with this for.
Yeah, go ahead.
So the COPD program is actually being managed through Brattleboro Primary Care. So you have to have a Brattleboro Primary Care in order to be eligible, and that's because for legal reasons. It's they're the ones that are allowing us to provide the services in the home. So there's a couple of different pathways. They're going to try to enroll every patient who has been admitted to the hospital, and we'll be following up with them for at least 30 days, depending on how they progress, because they're very high readmission rates. A lot of those patients, they get about 20, 25 days out, and they start going backwards in their cycle, and they end up back in the hospital, and that's a huge expense for the hospital because they don't get reimbursed. So that patient, the next time they're in the hospital, there is no payments for it. They own it.
Do you get reimbursed by insurance for those patients when you go see them?
So the hospital is paying for this 100%. So they're paying us 100% for this program to be able to staff this. Because at the end of the day, if one patient's not admitted, the program is paid for itself for the month. Literally is where it comes down to. The other pathway is, the other primary pathway is through the primary care offices. They have a lot of interaction with COPD patients, and when they recognize that the patient is starting to on that downward trend, they're going to contact us and refer them, and we'll provide a home visit, provide interventions, and try to stop that downward trend that COPD patients have. They have kind of a cycle that they go throughout the year, where they're on an upswing and then they go on a downswing. So, does that make sense?
So if there's a need for a change in the medications, the inhalers, the nebulizers, or whatever, does it go back to the doctor for the doctor then to order, or are you going to have that capability as well on the spot to authorize that sort of thing?
Through the protocols, there will be the ability to change and manage those medications. Ultimately, it's through the patient's care plan that's been established. Yeah, they'll be able to make those adjustments in the home with the patient in order to kind of help them on their path. So this is the next step. This is not the last step. So our program will continue to expand. And the way I look at it is really more options-based healthcare. I explained it when I was testifying up in Montpelier that right now, the way that our 911 system works is you pick up the phone when you're having that worst day of your life, you dial 911, and the operator says, is this a fire, police, or a EMS emergency, right? All right, well, there's 3 buckets. And the dispatcher's gonna take your call and they're gonna throw it in one of the 3 buckets. Sometimes they throw it in a couple buckets, right? Well, so they toss it in that EMS bucket, and then once it comes to us, we only have 2 options. We can take you to the ER, or we can leave you at home. That's it. Those are the only options we have. Well, we know that probably 70% of the patients that we see every single day, those options aren't right for. Like, we need something else. And what Mobile Integrated Health does is it allows us to have those other options. It allows us to provide that treatment at the house, effective treatment at their house, follow up with them, and not take them to the hospital. It may allow us to give them transportation to their doctor's office as opposed to the emergency department, because that's where they need to go. It may have us providing them telehealth from one of our computers directly to their physician as a way to not have to go to the hospital. And it gives us more buckets, more options. So it's really more options-based care is a way to think about it, is when, rather than having to wait until you're at that point where you're feeling so bad that you're gonna call 911, we're actually handing out a 7-digit number in partnership with Windham County Sheriff's Office, who will be running our dispatching, so that will be answered 24 hours a day by a dispatcher. For those patients that feel like they need help, but are not quite at the point where they think they need to call 911, there's a phone number they can call. And they can get one of our mobile integrated health providers to come to their house and treat them. They don't have to wait until they can't breathe in order to call us. That's part of the program that we're building. Super exciting work, and I think it's going to completely revolutionize the way that EMS is delivered. Nobody wants to go to an ER.
Oh, so it sounds to me, just listening to what you just said, it sounds to me like there's the possibility that there'll be some people that'll get missed because they'll dial 911. They won't know. How will they know about your 7-digit number? Communication program?
So the 7-digit number will be for those people that are enrolled. So as the program rolls out, right now we're seeing COPD patients, so there'll be a referral from their physician.
I see.
And with that, there's a care plan that comes and they'll say, hey, if you are, and we're talking about is kind of like a stoplight, okay? So in their care plan, if everything's green, that means that their day's going really well, right? If things are yellow in their stoplight, things are not going well, and maybe they need to start using some of those inhalers that they got for their COPD. And then it used to be that it was just a green and a yellow and a red, and when it got to the point of red, you dial 911 and went to the ER. So think about it this way, now we're gonna have a green, a yellow, and this orange band. And in the orange band, your doctor can say, hey, I want you to call this number. We know you're not bad enough to go to the ER yet, but we want someone to come to your house and take a look at you anyway. And as people get enrolled, that'll be part, and they'll explain through their physician's office that you're now part of this program. That's an opt-in. People don't have to. People can choose to. You're gonna be part of this program, and these are the services that we can offer for you. Other questions? Yeah.
Not a question, but an observation that you're rolling out this integrated mobile health, or mobile integrated health program as sort of an evolution of EMS and how it works with hospitals. And you're working with Brattleboro Hospital. It seems quite a backward step or a disjuncture for Brattleboro to withdraw from the group and purchase its own ambulances and assign them to the fire department. That doesn't sound as if it's exactly going to help communication. Again, that's just an observation, not a question.
Yeah.
Leave it, yeah. Just leave it, yeah.
Yeah, I don't know. And the regionalization of EMS has been identified as the number 2 priority, because that's how you're going to build sustainable EMS models.
Do you know what Brattleboro's paying per patient for their services at this point?
Way more than $25.
That's what I figured.
Yeah. And we'll get to see as they go through the budget cycle what that looks like. As well as we're going to keep an eye on what's happening in the Cheshire County side. I do believe that they're going to find that their initial price quotes were way under what their cost of delivery services.
Well, sorry, but then, so going back to your question earlier, if, let's say, one of those 2 locations decided they did want to opt back in, could they? I mean, you might not even be able to absorb them because you need this.
So we do have, again, so kind of back to the structure of the organization, which is kind of unique, I think. So Rescue Inc. is a nonprofit. However, each one of your towns is asked to provide us with a representative. So though the representatives come and they work for the better, the good of the organization, we do get feedback from all of our towns. So any town that's left, so once you've left, you're no longer a member. Everybody here is a member of our organization, member towns, which means that you're going to get service. It's kind of magical. You just get the service. Anybody that wants to come into the organization, our bylaws will allow people to come in at the vote of the board of trustees as a contracted town. So if a town wanted to come back, we could offer them a contract to provide service, but they would not be sitting in the room as a member town. They would not get a board member to vote. And there's a period of time where they would have to be a contract town before they would be eligible to become a member town and have a vote in kind of the way, in the direction of the organization. So they would have to, anybody that would want to come back would, send that interest to the board. The board would then either decide to make an offer or not make an offer to be a contract town. I think it's 5 years? I don't know. I can't. It's a few years.
It's the end of a cycled contract.
Yeah.
So if a town decided to come back in, would you actually provide the services for the same rate that you do for member towns?
So that would be up to
you.
the board of directors, or board of trustees to determine what those rates were. And I think it would be largely dependent on costs. So keep in mind that the communities that we serve have invested over 58 years into building the organization that currently exists. So our organization has many millions of dollars in assets and equipment that our member towns, our consortium has put together. There's value to that, and someone coming in, that's part of it. So what is the total cost? And if you are interested in kind of knowing what that looks like, you can go to the Swansea town meeting that happened in April of last year, and I laid out very clearly what the costs were, including what those build-up costs are, what those capital expenses are. Because here we're pretty fortunate in the sense that we have the equipment and we have the personnel to serve. If we were to add, say, another town and we had to buy ambulances and we had to, support those ambulances with equipment, we wouldn't expect our member towns to pay that bill. That wouldn't be reasonable. We'd expect if we were going to bring in another town that whoever that was would be owning those costs. Does that answer your question? As far as capacity, we can do anything here. Other questions? We've had some really cool projects over the last year. I didn't mention them up here, but we get asked to help the state with lots of different things. So you may or may not know that after the flooding last year, there's a lot of damage around Vermont. We got tasked with doing damage assessments in 7 counties, where we had to drive every road of every county and do assessments on damage. We got tasked with following up with all the people that had damages to their home under the FEMA agreement. We got tasked with making contact with every homeless person that was currently in a motel program in the state of Vermont. And our crews went out and did evaluations and questionnaires to determine where they were and what services they would need. Beyond that, we also were tasked with setting up emergency shelters when the hotel program in Vermont shut down for a period of time last year. So you never know exactly what we may be involved in, but as a general rule, we get asked to do a lot of projects to support not only locally but statewide initiatives. So like I said, I didn't highlight those, but that's just a handful of the other projects that we had going on in the last year.
Well, so just out of curiosity,
Yep.
So when these projects that aren't what you're normally doing come to you, are you free to say we're going to do this, or do you have to talk with the board?
The board, yeah.
And so there's a lot of quick actions that probably need to be made, decisions.
Yeah.
Yeah.
They're used to that. They're good at it.
Very good.
So the board gets together. We look at, how does it fit in our overall mission? What does it look like for us? We have our logistics team here is amazing. So, for example, the shelter program. If anybody saw the news about how that came together, it was 48 hours notice to stand up homeless shelters across the entire state. Each shelter was supposed to hold 100 people? I don't even know. 100 people a shelter, 200 people a shelter, with 48 hours notice. And I gave it to our logistics team at 8 o'clock in the morning, and by 3 o'clock in the afternoon, we had it fully staffed. We did bring in staff literally from all over the country. They had arranged for flights, hotel rooms, transportation, and the shelters were open by 5 o'clock that afternoon. So, and they're all the ones sitting in the back of the room. It doesn't really matter what I hand them. They'll put it together, and they'll put it together quick. They get all the credit. I just stand in front of people and talk. What else do you have? Someone's gotta have a really burning question. No? How about rumors? Rumors out on the street that I could address? I've heard people say we're going out of business. That's not happening.
Have you heard any rumors?
That was the one I heard, is that we're actually very sound. We're pleased to end our fiscal year just barely in the black, but in the black. So that's more than most services can say. So we're on sound financial footing. Staffing wise, we are very fortunate to have an amazing staff. Though we're always looking to recruit talent. Right now, we seem to be fully staffed, and we have been for a long time. So that being said, if anybody has, we never turn down highly qualified staff that's looking for employment. So our hiring practice is to always take the best people when they come through the door. But
Drew, maybe you could explain to them how quickly you put together things for when EMS and Keene area went downhill quickly.
So yeah, back to the amazing logistics team. We got that call on a Sunday that it was likely that the Deluzio ambulance was not going to be able to continue operating past Tuesday morning at midnight. So about 36 hours from when they called and said, is there any way you guys can help make sure there's continuity of service? So we called for some special meetings, not only with the board, but also our administrative staff. And we did stand up ambulance service for 7, 8, I don't even remember how many towns. How many towns did we cover over there? A lot.
Tell you all of them.
7 or 8 towns. And we didn't miss a beat. By midnight the next night, we were fully up and operational with trucks, equipment, personnel. Our HR director, who's not here, in process, I don't know, 30 plus employees that week. What the other part of the story, which is mildly entertaining, is we had taken on the Killington Search and Rescue Group the week before. So I just sent her an email saying, hey, I've got 14 new volunteers we need you to in process that are joining our technical rescue team. And then that was like on Friday. And on Sunday, it's like, hey, this thing just happened. Can you in process 30 new EMTs by Monday morning? And get them all trained and licensed in both states. And, we're very fortunate. Vermont works very well with us. We were able to license 30 people in about 2.5 hours. In New Hampshire, it takes almost 8 months.
Do you get any Vermont tax revenue?
As far from the state?
What does the state give you tax money?
So, not directly. We do receive grant funding here. So VEMSA has received, if I had to guess, I'd say like $350,000.
But it goes to special programs and
It
not
does.
to your EMS.
Correct. Yep. No direct connection from state tax dollars to us. But I would gladly recommend that. It says so right here. Hang on, let me get to the next one.
I was just
Right?
wondering-
Yeah, right here.
I was just wondering if we New Hampshire residents were taking advantage of taxes that we don't pay.
No, so we're actually really well balanced. So we've had this conversation a lot. So, for example, we pay our property taxes. I know it seems kind of silly, right? Most nonprofits don't pay property taxes. We have a building in Brattleboro, we have a building here, we have a building in Newfane, we have a building in Townsend. And if we were to be off the tax rolls in one of those towns, then that town's disproportionately paying more because in the way our tax structure works, they have to pay the tax anyway. So we have a very balanced system because, and I think that's super important, that everybody really pays an equal share of what it costs to deliver the service. The service is exceptional. I can't, I may be biased, but like what we provide is amazing service. You're not going to find another ambulance service I can tell you for the last 8 straight years they've hit 100% of their call volume. You're not going to find another service out there that can put up 3 Type 3 teams and 10 ambulances during a massive storm. It just doesn't exist. It's not here, not in Vermont, not in New Hampshire. So for what everybody gets and the stability, I think it's really well balanced. And we're grateful for the support we get from the communities, grateful for the administrative staff and the providers that are out there getting the job done. And like I said, hopeful that we can continue doing it for 3 more years. There are a couple things that are on the horizon. I mentioned it a couple times. 2026 is when the federal cost reporting data comes out, which means the federal government is going to reset the fee structure for ambulance services somewhere after February 2026. No idea what that means. If somebody can tell me what they're going to do in Washington in February of 2026, please do, but we have no idea. It could be better for us, it could be worse for us. We just don't know. But we're pretty confident here that we can continue to provide the service at 1% a year for the next 3 years. And certainly if something changes, something pops up on the horizon that doesn't look so pretty, then we'll pull a meeting together and make sure everybody knows that this is what we're seeing. But right now, there are no indications that things are going to get worse for us. Yeah.
Have you asked for 3-year commitments in contracts before?
The last
6 years.
6 years, yes.
Okay.
Yep.
This will be the third 3-year contract.
Yep.
And most of the reason for that is to provide, having been chairman of the select board for 6 years, it's really helpful when you get into budgeting season to know that's set. That's one less thing that you have to worry about. You know exactly what that number's going to be when you have to plug it in. And it just gives the towns a little bit of stability as they go into their budgeting cycle to know what their commitment is.
It also gives us,
Well, and
it
us
also
too,
gives us
yeah.
the ability to like move beyond that and kind of plan what we're doing over that period of time. Unless someone said, we had this meeting 3 years ago, and then we found out in March that, you know, we lost a big town, which had us scrambling. Thankfully at that time, we had some COVID money that we could draw off of, and we were able to, you know, absorb. We lost a whole, you know, we spent down a lot of savings account because of that. But we were able to readjust, kind of change our business model a little bit and made a whole bunch of adjustments, internal and external, to make it happen. But that was huge for us. That cost us literally millions of dollars in kind of lost revenue and money that we had put away for a rainy day in order for us to get out of that. So, you know, it'll take us a while to recover from those losses. But what we didn't have to do is we didn't close our doors. We didn't have to come back to the towns and tell you that we needed a whole bunch more money. We were able to kind of stay the course, you know, through that. I'm hopeful that everybody can get agreements back to us and, you know, we can have that peace of mind for the next 3 years, get through whatever 2026 brings us, and this transition to mobile integrated health will certainly take hold and do what we think it's going to do.
You deserve a lot of appreciation from the community. So you're very adept, you're willing to change, you're creative, you get things done quickly. Organizations like that are hard to find. So thank you.
You're welcome. We have a great team here.
Yeah, I had another curiosity question. Related to 2 pieces of information. One, you were talking about how the percentage of the population in Vermont is over 75 and how that's increasing. And then this mobile integrated health, the rationale behind creating that, and the focus now is on COPD and total joint replacement care, correct?
Yep.
Okay. Looking ahead, what other areas of treatment do you foresee moving into, like diabetes,
Yep.
You know,
So-
what? I'm just curious.
So I believe the next one, ultimately the decision as to what program will go next will be made between us and the hospital. I believe the next place we're going is CHF. So any patients with congestive heart failure will be the next group of patients.
And a lot of that is a lot of patients have both, right, as a diagnosis.
So, and with an objective to, keep in mind these are specialty programs, these don't exist. So the education modules don't exist for them, the protocols don't exist. So we're developing those protocols and then training for them. So like our orthopedic program, that was started from the ground up. everything from the protocols to the education. All of our providers have to go to the operating room, they work in the clinics, they work with physical therapy. So every time we add a program, we add significant requirements to the staff along with the education. The nice thing is we have this facility, so we can provide that education. So right now we're actively building and distributing the education module for COPD, and then it'll be CHF, and then it may be diabetes. They're also looking at things like cancer patients. They're looking at some of the other kind of areas. One of the areas that we're not currently looking at is mental health. And a lot of people ask, like, hey, you guys, what are you going to do in that realm? Right now, that space is full and chaotic. There's been a lot of legislative changes in the last couple of years trying to address mental health in Vermont, and they've made a whole bunch of changes around how the designated agencies in the state interact with certain response protocols and different rules, and so that space is really chaotic. So that area we're staying clear of until it settles down. We'll see if there's a place where we can work with HCRS in the future with our MIH program, but we're not getting into the substance abuse or mental health world because of that. Well, there's lots of snacks, and Danny would be upset if she had to pack them all up and put them away. So I would encourage you to at least eat some of them. I'll be here if you have any other questions. Any of the program directors, Josh didn't give himself credit and I didn't call him out on it. He's actually our technical rescue team leader. He's the one that's responsible for getting these teams out in all over the state, both states, because he was actually the one that's in New Hampshire responding to flooding last year. So if you have any questions about that, Josh, Chris does the mobile integrated health programs. If you need to know anything about money, Ellen is our money person. So she's the expert there. And Eric, who is probably out in the other room, is our general overall operations guy. So hit us up with any questions and please eat some snacks. Thank you all for coming out on a Sunday.
Thank you.